must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hey everybody, and welcome to the show today. Welcome to the podcast. My name is Brandon Pollen, and for today's episode, we sat down and chatted with Dr. Jean Timmerberg. Now, if you're unfamiliar with who she is, Jean is the current Associate Director of the Programs in Physical Therapy at Columbia University. She is an Assistant Professor of Rehabilitation and Regenerative Medicine at Columbia University Irving Medical Center. She serves as the co-editor-in-chief of the Journal of Clinical Education and Physical Therapy, and she served as the chair of the ACAPT Student Readiness Strategic Initiative panel. And her professional expertise includes orthopedics and clinical education, along with being a credentialed clinical instructor. Now, for this episode, what do we talk about? Well, we first talked about the ACAPT Student Readiness Strategic Initiative panel that Jean chaired. And for those of you who aren't aware, this panel was basically set up to identify and define a core set of competencies that are to be demonstrated by students prior to entering full-time clinical education. So they wanted to look at that. We also talked about some of her research involving site coordinators for clinical education, along with diving more into the Journal of Clinical Education and Physical Therapy. So it was a great episode. Jean provided a ton of insight and knowledge into these avenues. And well, without further ado, here's our interview with Jean. Well, Jean, I really appreciate, your service and all that you've done throughout our profession, and especially taking the time to speak with us today, especially with your busy schedule and all that you got going on. But I'd like to kind of dive in before we get into the topic today about, your story on how you really got involved with education and, how you've really gotten involved with doing all the work that you're doing specifically with clinical education and some of these other endeavors, if you wouldn't mind.
Sure. Well, thank you very much for having me. I appreciate you inviting me on to speak. So my academic journey actually began at Stony Brook University in New York. I actually earned a few degrees from there. My first was a Bachelor of Science degree in biology and psychology. And then I decided to stay on 2 additional years to get a second bachelor's in physical therapy. So I then worked for a little while and I realized that I was still drawn to the classroom. So I went back to school and got an advanced master's in health science from University of Indianapolis. And at that time, that was just when I became board certified as an orthopedic clinical specialist. And that's something that I, still hold on today. So while I never envisioned when I was in physical therapy school that I would actually have a full-time career as an academician, I kind of just kept getting drawn to the classroom. So when I was doing some lab instructor, I was a lab instructor for various courses. I lectured in a couple of different courses around here in New York, and I kept getting that draw. So because I realized that I loved teaching, I knew that I was going to have to go back to school to get an additional degree. So I went and I earned a PhD in research and education and health sciences. And that was from Truro University International. So I'm also a fellow of the APTA Educational Leadership Institute, which was really very helpful to try to pull a lot of different leadership roles together. So that has actually helped me, I think, in my role here now at Columbia. I am the Associate Director of the Programs in PT, and I'm also an Assistant Professor. So like I said, I never thought I'd be a full-time academician, but it's something that I kept getting pulled back to, and I'm really very fortunate that my path has brought me here, and I'm really lucky for it.
That's a wonderful path that you have taken, Jean. You know, the topic of discussion today is on ACAPT's Student Readiness Strategic Initiative panel. And ACAPT's website states that the goal of this task force is to identify and define a core set of competencies, which are included in knowledge, skills, and attitudes and professional behaviors that are demonstrated by students prior to full-time clinical education. So tell us a little bit about what you think the current problems in DPT academic and clinical education are that prompted this task force, and how the task force is addressing some of these problems.
Well, I wouldn't necessarily say there's a problem. I think that the physical therapy profession, we recognize that there's a necessity to meet current societal needs, and that they're changing. So we felt that as a profession, it's important to support any decision we make by educational research that will promote continued excellence in physical therapist education. So the work of the panel actually was initiated by some of the recommendations that came out of the Clinical Education Summit that was held in October of 2014. So those recommendations address the need for consistent student preparation. And that was the big issue, that clinicians were kind of speaking out loud, saying that students from different programs were coming at different levels that made it very hard for them to structure a great learning environment. So it was an increased challenge for clinicians. And the recommendations that came out, one of them was that we needed a requisite core set of what you just mentioned, Stephanie, that the knowledge, skills, attitudes, and professional behaviors, and we kind of lumped them into what we call KSAs. That's what it refers to. And really, it was the desire from clinicians was that we had that requisite core set for every student, for every entrance into. Some schools have 3 affiliations, some schools have 4, but that at each point we would have a requisite core set. So, currently programs, they vary in their sequencing and they vary in the specific coursework that students have prior to going out to the various affiliations. So that unwarranted variation really, like I said, puts a lot of, it makes it hard for the clinicians to really establish a good environment to meet the objectives that will really maximize that learning experience for the student. So it certainly came from the academic side, but it really came from the clinician side, that there's just too much variation. So we wanted to see if there was in some way that we could start to look at this, not to start, but to continue the discussions to see if we could certainly meet that need. So it came out from the summit. It also, findings from the National Study of Excellence and Innovation in Physical Therapist Education, they actually had a similar recommendation where it said that our profession needs to establish a comprehensive longitudinal approach for standardization of performance-based learning outcomes across the learner continuum that is grounded in foundational domains of professional competence. So we have various sources that are telling us we need to have a little bit more of a discussion on seeing where we can have some uniformity so that when students finish their educational component in a physical therapist education program, certainly they're going to continue to learn, but at least from there that we would have some uniformity.
Yeah, no, and that makes a lot of sense because I know that's been an issue that has been brought up, and I know there are a few other task forces or panels, that kind of formed as a result of the summit, and this being one of them. And Jean, I'm curious because you had mentioned, of course, the data in that study that kind of gave some other insight too. But how did this panel specifically go about collecting the data and kind of learning more about this? And apart from what you had mentioned there, was there anything else that the task force learned from doing this initiative, kind of regarding this issue?
Great questions. Well, just to give you a little bit background about the panel, what we did. So our goal of the panel was to come to some consensus, which is a really hard word and a hard thing you can imagine for everyone to kind of agree upon. So we used a Delphi method. And if you're not familiar with the Delphi method, what that does is it engages a group of participants or experts, and you go through multiple rounds of surveys to try to establish consensus on a particular topic. So what we did is we reached out to program directors from ACAPT institutions, and we asked them to nominate 4 individuals. We asked them to nominate a physical therapist, a core faculty member who part of their responsibilities were working with students prior to that first full-time clinical experience. We also wanted a DCE or an ACCE, whichever their title was, that had at least 5 years experience being in that role. We also wanted a clinical instructor that had taken at least 5 students on their first full-time clinical experience. And we also wanted a recent graduate who had graduated from an accredited PT program and who also passed the MPTE exam, only because we were a little worried if they hadn't, that there may be a little bias there. So we asked them to nominate 4 people, and then so all of those invites came in, and then we extended the invitation out to those individuals. And then we went through 4 rounds of the survey. And the challenge with the Delphi is there's quick turnaround. So you give a survey, the participants have to respond relatively quickly. The researchers then have to go through what they need to go through and get the next round out in roughly 2 weeks, which is tough, especially when you're trying to get everybody to meet, the same time. So we developed the survey, which really, the survey had really 3 open-ended questions, and we certainly had external reviewers look at it. But just to kind of give you an idea about the 4 rounds, in the first round, they answered the 3 open-ended questions, which really was saying, what do you think that every student, no matter what program they come from, no matter where that first affiliation sits, no matter what setting it is, what should they look like? And it was really like, what do you think is essential for that person to have? And then we also got into, if they're supposed to look like, they're supposed to have X, Y, and Z, what would be the best method to assess that they actually have X, Y, and Z? So that was the first round. In the second round, what we did is we organized all the things that everybody wrote, and we called them, just moving forward, we called them elements. And all of those elements actually were organized into themes. So we had a whole bunch of elements, items if you want to call them, and they eventually kind of fell under about 14 themes. But in the second round, we just asked, does anything need clarity? Is anything redundant that you think we should take out? So we had a little bit of feedback from that, and anything that seemed redundant, we took out. In the third round, this was the tough one. This is where that we brought that list back that now hopefully was clear and didn't have any redundancy, and we asked individuals that were participating to rate their agreement with each of those elements on a 5-point Likert scale, whether strongly disagree to strongly agree. And we define consensus as if we had more than 80% of respondents rating it as either agree or strongly agree or strongly agree, that it made it to our final list. And then in the fourth and final round, they looked at all those elements that gained consensus, and then we asked them to kind of give it a level of what we call level of competency. So for a particular item, did the student need to be familiar with it? Did they need to be efficient with it? Or did they need to be proficient with it, which is kind of like the highest level? And those 3 categories have been defined in the literature, and it's kind of based on the complexity of a situation, if they need supervision or not. So it gave us an idea of how much breadth that student needed to have when they first came in. So it was a pretty busy process during a short period of time, so we really appreciated all the input that everybody, all of our, participants, and we ended up with 95 elements that got consensus. Again, fell under 14 themes. But just when people heard that, they were like, wow, 95 things, but let's not make it seem so big. Only 9 required the proficiency level. And out of those 9, 3 of them included things like that they had the minimum GPA that the school required, that any safety issue was remediated, that they passed all practical exams. So those 3 are pretty, most schools you have to have that to stay in the program. So it was pretty easy. The remaining 6 all fell under the affective domain. And I could just read them to you. It was to demonstrate polite, personable, engaging, and friendly behaviors. Introduce oneself to the CI, have respect for patients, peers, and healthcare professionals, be punctual with all assignments, understand HIPAA regulations, and have the appropriate dress code. So those 9 things were the things that our participants felt all students had to be proficient in when they began their first full-time clinical experience. So I think that calmed a lot of people to say, I mean, most of us, I should hope we're doing that. But if you looked at many of the other items, if we collapsed our data a little bit and looked at things that may by themselves, if we collapsed those items that needed to be efficient or proficient, we then had a large number. We then went up to, I think it was 58, but all of them really, I shouldn't say all of them, but the majority of them fell into the affective domain. So it really made us feel that, and a lot of the literature can back this up, that most clinicians for the first full-time clinical experience really wanted students to be knowledgeable about different things that like communication, professionalism, that really, it really wasn't a focus on psychomotor skills. So I think the results of our study, again, highlight the importance of the affective behaviors, and that, it may enlighten programs to kind of look at their early curriculum to make sure that those courses or maybe modules within those courses address those prior to going out on the first full-time clinical experience. So I think that was, helpful to know, to have that information. And I think the information can help programs maybe look at their curriculum and help guide some small changes. And, some of the items, if they just were familiar, as long as programs addressed that within their curriculum early on, it was okay. But there were some other items that they needed to have more in-depth knowledge on. So I know for us here, like we looked at our curriculum and we said, maybe we should have an additional module on this so that they go a little bit deeper into that area. So it was helpful for us, and I'm hoping it was helpful for many other programs.
I think that it's great that you guys have been able to do this study. And I know that with the Delphi study, that's one way that we can look at these things. Is there any other current best evidence that talks about best clinical education competence for PT and other healthcare provider students besides this study that you guys have published?
Well, there's, yes, the long-winded answer is yes. Short-winded, I should say. Well, I personally, I always have this, it's kind of like a pet peeve of mine, that I don't think there's we should distinguish between clinical education competencies and educational competencies, because it's all education. Whether it occurs in the actual classroom or whether it's in the clinic, it's all learning. So, but, you say, like, some people have used the word that it's broken, and we're like, no, it's not broken. I think, like I mentioned before, we realize that the societal needs have changed, so we have to look at our profession to see what we can do to make sure we're meeting societal needs, because that inevitably is what we're doing all this for, right? We want to make sure we maximize the outcomes of our patients. But in about, it was probably in 2000, there was a study that was published. I think it was Cohn et al. That noted that patient safety was really becoming a health issue in this country. And there were some scary numbers that they published in that study, where the authors reported that there were about 44 to 98,000 annual deaths due to medical errors in hospitalized patients. And if just to put that in perspective, so 44 to 98,000 deaths due to medical errors in hospitalized patients. If you look at other numbers, 43,000 annual deaths are from car crashes, 42 are from breast cancer, and 16 annual deaths were from AIDS. And this is based on numbers from 1999. So it's kind of eye-opening, and studies like this are part of the reason for the push across healthcare, but probably leading in medicine, pharmacy, nursing is certainly moving this towards moving away from time-based learning and moving more towards outcome-based or competency-based education. So in essence, competency-based education looks at outcomes more than process. So it's just because you spent 3 years in a PT program doesn't mean you learned anything. We could teach things to you, but did you learn it, to do that? So the goal of all of that is, safer and higher quality care. So, competence is assessed, not assumed. And I think a lot of the literature out there is now supporting, looking at this, and certainly in physical therapy, we're looking to see, is competency-based education something that physical therapy should be considering?
Yeah, and Jean, if you don't mind, can I ask one follow-up on that? Because you kind of are bringing that up. Because I know we've had a few people on, and there's, of course, been new emerging themes, of course, about EPAs and how should we look at outcomes, like what should our outcomes be? How can we standardize them? And I know this could probably be a whole total different episode of itself, so I'm not trying to go down a huge rabbit hole here. But from your understanding and how you see things, what do you think is probably the best way or thoughts on how we should do our outcomes?
Well, and it's a tough situation. So I think we as a profession, need to think about what do we talk about the learner continuum. So maybe when you enter PT school, different points along on PT school, when you enter into practice, and even continued competence. And we really don't have we don't have that right now, So, I think as a profession, we need to think about what should that person look like ideally. And what do we base that on? Societal needs. So this has to be from multiple stakeholders, not just in PT, other professions, patients, students, everyone. We have to kind of have the conversation to say, what does that person need to look like? And most of it we're already doing. So it just maybe have it more of a formal, putting it all together, like that we all try to have some, I don't want to use the word standardization, but have some, that everybody meets certain requirements so that our clinicians know what to expect when students get in there. And even, like I said, even continued competence, it's not just physical therapy students when they finish PT school, So I think we need to look at that. And once we have that description, which will take time, then we can figure out how to best to assess it. So I think we need to define what they look like and then figure out the best way to assess it based on research and also feasibility.
No, that's a good point. And I totally recognize that's a huge topic with so many tentacles attached to it, but it's something that's definitely been brought up. And I think you bring up a good point that there's so much we need to know to kind of figure out what that way is and how to kind of integrate it together. And you had mentioned a lot of the results kind of before about, the ACAPT panel. And I know they came up with 5 recommendations that you guys presented to the ACAPT board of directors. That's, available in the show notes to everyone who wants to take a look. And also, Jean did a presentation to the board of directors that's also in the show notes. But would you mind just giving a very brief summary of these recommendations that you guys presented?
Sure. Just to follow up to just before I do that. So the results of our student readiness, the Delphi study, it's funny that those 14 themes that I spoke with, they actually align with the 12 competencies that medical students have to demonstrate before clerkships. And all of them are represented within the 8 domains of competence that the AMA established for progression to residency. So there are definitely some similarities there. But anyway, so moving on to your question. So there were 5 recommendations. And the first one is that our list of 95 elements under 14 themes, that list be adopted. And then the second recommendation was that ACAPT develop a plan, including an implementation guideline to guide programs to assist in implementing this list, and also to communicate with our clinical partners so that they are aware that we heard you. We want to have some consistent standards for students when they enter a first-time clinical experience, but we need to kind of get the word out. So we need to get it out to academic programs, we need to get it out to clinicians, and then we need to assist both groups to try to see if we can now follow this. Because it's great that we have this list, but if we don't do anything with it, then it was kind of, it's kind of moot then, So and the third recommendation is that ACAPT encourage in programs to evaluate their curriculums to see if they need to make some subtle changes to maybe include modules earlier so that the students meet all the requirements on that list or recommendations on that list. So maybe, like I mentioned before, a program may have covered a particular area, but maybe they didn't go in depth enough, so maybe they need another module, or maybe they're already doing it and it's fine. But we want to make sure that ACAPT provides support to programs so that they can maybe make some tweaks to their curriculum, or at least to look at their curriculum to see, are they already doing it? And many programs already are. So it's a lot of the stuff we're already doing, which is great. The fourth recommendation is that, so we looked at student readiness for entrance into that first full-time clinical experience. So our next recommendation was that we need to look at other points along the continuum. So we had at that time recommended maybe looking at students right before they go on their terminal clinical experience. So before they've completed all their didactic coursework, but they're now going out on their terminal clinical experience. So that was the fourth recommendation. And then the fifth recommendation was, so now we have all this, what the learner should look like, but then we need to have additional educational research to follow up to see what's the best method to assess all of those things that were listed. And that's really kind of what we spoke about before, but that's kind of what came out of the panel.
You talked about how some of these recommendations are already being implemented. What changes, can you maybe expand a little bit on that? What changes have taken place since you presented these recommendations to the panel? And where do we go now from where we're currently at to continue to make these changes?
Great question. Certainly the work of this panel is not the only thing that was looking at readiness. There have been many, many groups, and even in the literature looking at especially entrance or entry level. We like to say entrance into practice, but so a lot of work has been done. And even through our work, we realized that other groups were doing things and we didn't want to reinvent the wheel. So there was a lot of, different, I don't want to say groups because we're all we're all one team, but different things were being done and not everybody knew about it. And I think that's probably one of the reasons why there's now the Educational Leadership Partnership, so the ELP. So in 2016, the Educational Leadership Partnership was established, and it's not a new group. It's just 3 partners that have joined, I guess you could say joined forces. And really their mission is to drive excellence in physical therapy education, to really raise the bar, but also to not have a redundancy of groups doing the same thing, because we all have enough work to be doing, and we know that all of this stuff is being done outside of people's normal jobs. So let's not have multiple teams doing the same things or, work together. So I think that's really great. And so the ELP meets at every national meeting. They also have monthly calls that they update on so the 3 partners are APTA, are ACAPT, as well as APT, the Academy of Physical Therapy Education. So even though there are 9 voting members for ELP, 3 from each partner, there are also multiple people that are involved, multiple stakeholder groups from accrediting bodies. So CAPT is represented, FSBPT is represented, residency and fellowship. There's a large clinical community partners. So it's really great that this partnership has been developed, and they're really trying to maximize our time to really maximize the education of not only our physical therapy students, but beyond that. So I think it's really great. And they, just so you know, they do have an annual report that you can view if you go to, it's apta.org, and I think it's /ELP. You can see all the work that's being done, and it's really trying to be transparent so that everybody can see what everybody else is doing. And if you want to get involved, or if you just want to see what the results were, it's really great that the communication between everyone has really ramped up. And I think that will help.
No, I completely agree. And, even just seeing what they've been able to do in a relatively short amount of time. And, they recently just did their 2018 final report not too long ago, if I'm not mistaken. Yep. And it just provides a wealth of information on what they're doing, but not only that, why they're doing it and kind of what they're looking to do. So I would highly recommend, if you want to learn more about that, to take a look at that report. And if you want, we'll put it in the show notes here. But Jean, I want to switch gears here a little bit to kind of get away from the panel a little bit, not because I want to, but just because I know there's some other good stuff that you've done. You're also the co-editor-in-chief of the Journal of Clinical Education. I know this is kind of a new thing, and some people may not know about that, but tell us a little bit about the Journal of Clinical Education.
Yes, well, thank you. So the Journal of Clinical Education and PT it's abbreviated JCEPT. So we do have, it hasn't fully launched yet, but it will be launching in the next month. So if you go to jcep.columbia.edu, you can see our launch page. Really, one of the, our main goal, unfortunately, not every physical therapist is a member of the APTA, which is something we all need to try to keep encouraging. And certainly membership into different academies now are not as high as we'd like for them to be. So a lot of the information and great work that's being done that gets published in the different journals are membership access. People have to be members to have access to that. So especially clinicians seem to be, unfortunately, a lot of the funds for membership have been reduced at institutions. So it makes it hard for a clinician to, figure out where they're going to spend their benefits. So we wanted to have an open access, peer-reviewed journal for educators, for clinicians, so that everyone would have access to it. So it's an open access peer-reviewed journal, and we really wanted, our mission is really to certainly build evidence-based related to education, but we really also wanted to facilitate the development among physical therapy clinical and academic faculty of the future. So, if you have someone who's a clinician who really wants to get involved in education, where do they go for a resource if they're not a member? So that was one of the things that we were hoping to kind of address with having this open access site. We have a wonderful editorial board with years and years of experience in different journals, and also associate editors as well that have various backgrounds. They're clinicians, they're academicians in different areas. We have some that are more involved in continuing ed, so various aspects of education. So we really thought having this venue or having this platform for research would be wonderful. We also, one of the nice, I should say, if you're not familiar, and I actually learned this from working on the journal, is there's a thing called open peer review, where if an author submitting an article agrees to it, they can have the feedback that the reviewers provide be actually published. So there's kind of two learning points there. So an author who is submitting or may potentially submit on a subject will learn from the feedback that others have been given. And the other thing is, if you are a person that would maybe interested in becoming a reviewer, you can learn by reading what other reviewers have provided. So you can kind of get a win-win situation where the author who is submitting learns, a potential author who may submit related research can get have a learning situation, as well as maybe a therapist who'd be interested in becoming a reviewer for a journal. It's not something that we're really taught a lot about in PT school or even after PT school. So we're really excited about this, and we're really hoping that, individuals will be interested in submitting. So we'll be launching next month, and we're really excited for that.
I know, Jean, that you were the lead author in a research report called Defining the Role of the Center Coordinator of Clinical Education, Identifying Responsibilities, Supports, and Challenges. For our listeners who haven't read this article or haven't heard about it, can you kind of talk about the purpose of your study, maybe some of the methods that you used to conduct it, and then what you found with the results of your study?
Great. Yes, that was a great experience. So I think we would all agree that the CCCE, or now the updated terminology is the SCCE, the Site Coordinator of Clinical Education. They are a critical component in ensuring quality of clinical education experiences, hands down. But little is known about how today's SCCEs are performing this position. So the purpose of our study was to identify how SCCEs define their role and associated responsibilities in current practice. So how are they prepared to be an SCCE? Maybe the structure of their clinical learning environment where they work, and the available supports and challenges that they may encounter during their day-to-day activities. So, as you know, there are an increasing number of PT programs that are being developed, and current programs, some of them are increasing in the size. of the number of students that they have, as well as the number of weeks that clinical experiences go over. So that in combination with the ever-changing health care needs of society has certainly placed additional demands on clinicians, CIs, and certainly SCCEs. And it's making it harder for clinicians to provide these high quality clinical education experiences. So we really wanted to see what are the challenges, and maybe to see what could we potentially do as a profession to support and to try to decrease some of those challenges. So we sent a survey out to, we used the CPI database, and we identified all the SCCCEs, and and we certainly put it out there, and a little over 1,100 SCCCEs participated in this online survey. So we asked various questions, how do you do this? How do you do that? How do you schedule students? Is it you? Is it someone else? What are some of the challenges? What are some things that we can do to help you? So the results of the study, we found that, most CCCEs, they schedule the students, they meet with the students while they're there, they provide an orientation, they monitor, novice CIs, and they also assist in crisis intervention when there's a situation that's going on. But most SCCEs report that they don't have enough time within their workday to do all the tasks. So they end up doing a lot more outside of their job, which you can imagine just puts even more demands on that individual. Fewer than half of the respondents were given support to attend professional development related to clinical education. Less than half had a job description for that position, and less than half had their role acknowledged on their facility's career ladder. So most CCCEs indicated that they had not been mentored in this position, but those that did really felt that it was valuable. And that was something that was really highlighted, that mentoring in this position was so valuable to those that received it. But just to give you a little bit, and this kind of was one of the impetuses for the Journal of Clinical Education and PT, we took some demographic information from those 1,100 participants, and 52% belonged to APTA, and out of that 52%, less than 6% were education section or Academy of Physical Therapy Education section members, and only 17% were members of a clinical education consortium. So, and now that could be that maybe they didn't know one was aware that a consortium was around, or maybe they didn't have time for it, so we're not really so sure why that number is on the lower side. And that's certainly something that we could certainly look further into. So the bottom line is there's certainly a considerable variability in the way individuals define and perform the role of the SCCE. It seems like the structure of the clinical learning environment really impacts the quality of learning experiences offered, as well as the staff's willingness to participate in clinical education. So many resources are certainly available for SCCCEs through our professional organizations, but as we mentioned, most of our respondents were not members of the APTA, and even less were members of the sections, or the academies. So they may not be aware of these wonderful resources or have the ability to have access. So that was certainly a challenge. SCCEs really asked for some support in their professional development, but because of time constraints, they felt that online modules would be the best thing to try to address some of their challenges.
Gotcha. And I know you had mentioned quite a lot of the limitations or things to consider, what you had just said, and there was a few in there that you mentioned. But apart from what you said, were there any other big limitations that struck you guys while doing the study that might also kind of explain why you guys found what you found?
Well, I mean, first and foremost, we gathered our participants from the CPI database, and CPI is not mandated by ACAPT, so there are many programs that don't use it. So obviously, we were not targeted. We did not solicit feedback from all SCCEs, so it certainly may not be generalizable, and they may not have had their ability to kind of provide feedback. So while our N certainly seems pretty high, our response rate was a little over 12% because we sent many requests. So while the results represent we got respondents from varied clinical rotations and settings across the nation. So every state was represented, but the findings may not reflect the experiences of all SCCCEs. So we also recognize that there are additional factors that can contribute to the effectiveness and satisfaction of the SCCCE, including their own personal motivation and even an individual's commitment to clinical teaching. So it may not just be that they don't have enough time, but there are personal factors that could have an influence on some of the responses. So we realize that, but we just found some themes that seemed to come out, and we just wanted to see if we could help.
Perfect. Your group had mentioned in this study that many resources for the CCCE are provided through professional organizations. And the results of the study indicate that many respondents are not members of such organizations and may not have access. So you talked a lot about how, we're not utilizing the resources maybe of the APTA or of the Academy for PT Education. So what do you believe are some solutions that can help bridge the gap and improve the reduction in variation with CCCE's performance across the country? And maybe even if you could comment on potentially why you don't think people are utilizing the resources of the APTA or the Academy for PT Education.
I'm not 100% sure, but I don't think it's that people aren't using them because they don't want to. I think many just aren't aware that they exist. So I think communication, we need to work a little bit on that communication with our clinical partners, and I guess, I'm putting a little plug into the journal. That was one of the reasons why we wanted the journal. We wanted it to be free for people to have access. And, we're going to try to see if we can, we're going to have a communication and announcement board to see if we can really get things that people are doing nationally out there. But I think, when faculty members go out and do site visits, I think we need to make more of an effort to communicate when we do site visits. Or, technology is wonderful, but we all know that we get inundated with emails and other things. So how do we know that those things will be open? So we have to look at various methods to see if we can communicate a little bit better. And we're doing that. I mean, we're all trying to do that. So, but as I mentioned before, funds for therapists related to professional development, I think, are a little bit on the downside. So, clinicians have to make, a judgment on where they're going to spend their money. And a lot of times our funds are put towards courses with specific content related to maybe, orthopedics or neurology. We don't see as many people spending that money towards professional development related to education. So, and it's just life. So if we can try to see if we could maybe have reduced costs to those kinds of things, or maybe if we could see if we can look into maybe some grant support to provide membership. Maybe there's a reduced institutional membership, if not free. It would be great if clinicians could have access to those wonderful journals that unfortunately require membership. But many of the journals now have an open access, potential component. It just becomes a little costly. I think, we should try to maximize using technology that can hopefully bring things to communicate the wonderful things that the profession is doing to more people, but not just using technology, because we know that many people aren't comfortable with that. So we have to kind of work together to, like I said, on site visits, or maybe, at national meetings, or just trying to communicate as many things as we can so that clinicians know what's available for them.
What are some of the resources that APTA and the Academy for PT Education have for SCCEs that they can access to help improve their programs? Tell us a little bit about them. We have a lot of people that do listen to our podcasts who are not APTA members, so this is a great time to kind of talk about those resources.
Well, as I mentioned, the three partners, so APTA, ACAPT, as well as APT, they have wonderful, if you go to their website, and you'll see that there's a manual for SCCEs. There's certainly, in terms of clinical education, there is the CI, the credentialing that's out there, and a lot of consortiums are trying to provide those seminars or those courses for their local affiliates. So it's really trying to see maybe if you can get involved in a local consortium. Usually they love having clinicians. It's usually very more than half of consortiums are academic side, but they really, all of us are always loving when we have clinicians that can attend. And a lot of consortiums have some supports to try to support clinicians to attend. They certainly don't pay salaries to have free time, but they can support travel potentially. So I encourage any clinician or institution to try to see if there's a consortium that's nearby that they can participate in. And I know that there's the NCCCE, the National Clinical Consortium of Educators, and that they are really trying to partner with having clinical partners kind of align with academic institutions to try to provide as much support to those partnerships as possible. But there's definitely manuals online for the SCCE. There's lots of great literature on qualities of good clinical instructors, effectiveness in clinical education, different characteristics of learning environment that seem that the literature supports that creates or maximizes students' experiences, not just in physical therapy, but outside of physical therapy and other healthcare professions. So my suggestion is to look on the different sites and to also see if you can partner with a consortium. That would be really great.
No, that's really, really helpful, Jean. And, it's interesting. In the past, we had interviewed Ellen Weatherby to talk about her program and how they kind of do a clinical readiness program and practicals before students go out to the clinic. And of course, after doing more research, I found that you both were involved in writing a paper for the Journal of Physical Therapy Education, which is called Essential Characteristics of Quality Clinical Education Experiences, Standards to Facilitate Student Learning. And what's funny, Ellen had mentioned when she was on her episode about there being a credentialed certification option for clinical educators. And this was actually a recommendation in this paper here, which, I think is interesting, seeing how, of course, APTA has modified the credentialed clinical instructor program. But of course, as we know, with students and clinicians facing, of course, the financial constraints, reimbursement challenges, maybe not having support from a financial standpoint from employers for certain things, across the country. And I recognize that earlier you had said some things regarding for the SCCEs with, reduced finances, more open access to resources, and technology as some solutions. What are some ways that we can kind of make this kind of improve the ability and so we can reduce the unwarranted variation of clinical instructors to ensure their quality development, but also having it be financially feasible, incentivizing so them to actually be able to do? Like, what are your thoughts on how we can do is kind of the similar thing for SCCEs to clinical instructors?
I personally think it's really a lot about acknowledgement. Like I mentioned in our study, we found that many SCCEs didn't even have a job description and their role was not acknowledged in the career ladder. So I think we need to kind of market a little bit better to really acknowledge that position and really the role of the clinical instructor as well. I do think in other professions, I always think about the TV shows that I watch. I'm a big Grey's Anatomy fan, that you always have like their educators kind of put on this pedestal when you have the attending that comes in. And I don't think we elevate our clinical instructors enough because, their role is so imperative. And I feel that they need to be acknowledged more and supported in any way possible. So I think we have boards. I'm an OCS. I'm board certified in orthopedics. There's certainly many other specialty board certified specialists. But would there why not think about having a board certified educational specialist? Mm-hmm. All of us are wonderful clinicians, I hope, and I really do believe that. But maybe not everybody's meant to be an educator.
Right.
And we've all had experience in our own careers and who we work with, that there are some people that are just phenomenal educators, and you really want to help them and have them continue to support and really continue along that path. Maybe not necessarily formally in an academic program, but in the clinic. And I think if we could try to maybe as a profession acknowledge something like that, some kind of elevated credential status that, that would encourage those that have done really well and really want to continue, that really want and value education, to continue to take students and do such a great job and have that mentorship and have that feedback. I think, like I said, not everyone's meant to be an educator, so why not have those that do it well and really value it? Let's let them continue to work with students and really try to support them in any way we can. So, I know we certainly have a lot of students, so we're going to have everyone who takes a student be a board certified educational specialist? No, but they could be there to certainly help and guide others. And many programs, big institutions that have wonderful clinical education programs, they have mentorship programs within their institution where they have what's some places called a senior CI. So you have somebody who's the mentor who helps the novice CI. So maybe that board certified clinical education specialist is the one who is the mentor for that institution, and that would be great. I think we need to elevate the status of our educators in the clinic. I definitely think we do, if there is such a thing, if we can do it.
Yeah, I totally agree. I think that, clinical educators are part of how you produce an amazing clinician leader. And so I think that you make a really great point on that. This has been a really great discussion, Jean. I think that our audience has learned a lot. I know I've learned a lot. With every interview, we wrap up with a question that we ask all of our guests. So I'm going to ask you that question now. If you could change one aspect of healthcare education in DPT or otherwise, which aspect would you change and how would you change it?
It's funny. I was trying to think about the question. It's a hard one to answer. I do think in our profession as well as healthcare professions, I think we have been so focused on the process. Students enter here, they spend this time, and then they graduate. And certainly we have exams going through that, that they've met certain requirements. I think, we know that our students come out with a lot of debt, as do other healthcare students. So where can we trim things that would be okay to trim things? And I think, and this is not just exclusive to PT, like we always want to give more. We always want to teach more and add more, but our students, they have to absorb and learn. And so I think we have to be a little careful with adding too much. If we recall when we graduated PT school, it's not that you stop learning, there's continued learning. And I think, there's on the job learning too, so we have to feel comfortable with that. And I think we need to say, do we really, currently most of our students have a 4-year undergraduate degree, and then they go on for roughly 3 more years, and then they graduate with the DPT degree. Are there ways that maybe, remember, the affective domain areas, communication, professionalism, can we start that more on the undergraduate level? Can that be a prerequisite maybe, so that we can reduce some of the time that they need in their professional training? Or maybe can some of the beginning courses, foundational sciences, be moved more towards the undergraduate side? I'm not sure, because we know that some of the courses, we want to make sure that they're getting what we need for the students to get. But I think we need to think outside of the box that way to see how we can still provide the great education that we do, and if we can somehow think about reducing some of the cost of that. I also think, interprofessional education is wonderful, and I think the buzzword is continuing, which I'm really happy about. And maybe there are ways that we can do things with other professions that can reduce some of the cost of having the same kind of courses being provided in multiple professions. If we can share those resources, that may help with some of the costs. I think we need to move away from time-based and move more towards outcome-based, because like I said, we can teach a lot of stuff, but do the students really truly learn? And I think that's why we have to move towards, we should consider moving towards more of a competency-based approach. That's just in the we're just in the discussion phases of that. And, we're trying to move to see if that is something that physical therapy professions should consider. And I think we've all learned that we need to have research to kind of justify or back what we're doing. We don't just want to try something and say, oh, well, it didn't work, and then, and move on, So I think that our profession is doing a good job of that, to say, let's try to look at doing some research to inform our decisions, which is great. But I do think that we need to think about ways of trimming the length of our programs, as well as that, which would inevitably decrease the cost. But there are certainly, I know ELP, the partnership has a panel or a task force that's looking into student debt. And I think I'm really looking forward to their findings to see if that may kind of do some of the things potentially that we were just discussing. So we're a great profession. I just think we have to try to see if we can trim some of the cost a little bit.
And that's our top answer on this podcast, is cost of education. So it's a big problem, and hopefully somebody can solve it.
Well, I also think, you may be hearing, there's a few medical schools that are now they've gotten support so that students don't have to pay for tuition, or, it could be financially based, or some schools are even just providing free tuition to students. And it's something that we're thinking about here at Columbia, to see, could physical therapy do the same thing? Could we find ways so that, you have a strong student that would be excellent in your program, but they can't come because it costs too much money. So we don't want to lose those individuals. So we have to kind of think of ways that maybe we could do the same. So. Yeah.
And, I hate to throw a wrench in here, just because as soon as you said that, my mind immediately goes, how do we convince the Board of Regents to do that?
Well, I know here at Columbia, and I know there are some other schools here in New York that they had endowments that paid for that tuition. So I just think in our profession, we're not used to having such endowments. So we have to kind of figure out other ways to do that. Maybe that could be part of it, but I think we're going to have to look into other avenues to support such a thing. But it's just something that we have to keep trying for.
Agreed. Always trying. Well, I know people are going to have questions after they listen to this podcast. So where can people follow up with you if they do have a question?
Sure, I'd be more than happy to speak with anyone. I think the first point would probably be my email, and I'm frequently on that. So that is jt2634@cumc.columbia.edu. And that's, you can certainly reach out, and if I can answer your question, I certainly will. And if I can't, I'll try to figure out a source to help you answer that question.
Well, perfect, Jean. Well, again, this is, like Stephanie had said, this has been a very enlightening discussion. I've definitely learned some things about, this that I really hadn't beforehand. So I really appreciate that. And I know the listeners will as well. Thank you so much for your time and everything you're doing. And we wish you the best with everything you're doing with, of course, clinical education, the journal, and everything at Columbia. And, thanks so much for spending the time with us this morning. It's been a pleasure.
Thank you. Thank you very much for having me. I enjoyed it.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.